for everyone who stayed. Thanks so much for staying. I think this is a really important conversation when we're talking about students and personal protective equipment, fit testing, what OSHA requires, what facilities require. It's kind of a weird landscape to navigate. So thank you everybody for staying, and super thanks to Bryan Goodin, who is here from Legacy Health Systems. He is a respiratory protection expert, and you also said infection disease control expert, right?
Expert is a scary way to start, but I'll say I specialize in
that. Yes. Yeah. And I don't know who are you watching the Super Bowl this weekend?
I'll probably be gardening, honestly.
Well, it sounds like you've got Carol Easter that's giving you some thumbs up there. I think that pretty much based on what we have just heard, a lot of people are going to be gardening or going to RV shows or watching commercials or something like that. So thank you, Bryan, for being here. I'm going to just turn it over to Bryan, if I could, and let Bryan just kind of like talk a little bit about some of what you know, just an overview about PPE for students, or just PPE in general that are related to students. And if any of you who are on the call, if you have any questions about this, go ahead and put those in the chat, or after Bryan's done, we'll open it up for questions and you can just ask him directly. And when we're done, we're done. You don't have to plan on staying here for longer than 30 minutes, but we'll try to wrap this up as quick as we can. But we do absolutely want to get your questions answered. So Bryan, turning it over to you.
Thanks for having me. I see some familiar names and faces. So hi everyone. Quick background, Bryan Goodin, I manage employee health services for all of Legacy. So that's the 9 hospitals and 200 and some ambulatory settings. I'm a public health nurse, and my background is occupational safety and infectious diseases. So you can imagine it's been a fun couple of years for me, just like probably for the rest of you with all this, pandemic and whatnot. At Legacy, one of my department roles is selection and management of PPE. So that puts me into OSHA's designated respiratory protection manager for the system. OSHA requires every healthcare administration that uses respirators in their setting to designate someone as the respiratory protection program manager. So that's one thing that I'll always point out to folks who are having questions or running into barriers is if the place is giving respirators to their employees, they have to legally by federal law designate someone that you can go to interact with specific questions. If they can't name that person, that's probably a sign that they're having some struggles keeping their program together. But usually that people can find that person. It should be very clearly designated in the policy of any administration that's using respirators. I don't really feel like a PowerPoint or anything is necessary. I thought I would just kind of roll through some of the stuff that I had exchanged with Jana and Wendy, and then I'll just open it up to questions and we can dig into anything that might spike an interest. So one thing I will say is if you're confused, you're not the only one. It took Legacy and myself about 2 years to get our heads around OSHA's crazy new requirement for respirators, which I think is coming a little bit late to get much buy-in. So in addition to the rule being wacky, a lot of hospital systems and especially hospital employees are dragging their feet. So you might hear an answer from me that you have not seen implemented it in certain settings. Likewise, there are some hospitals that are wound a little too tight or have their act way too together and are exceeding the minimum requirements of OSHA. So you may also have been in placement settings, because I believe most of you are clinical educators and over that kind of population, clinical students. If you go through a variety of settings, you're going to see a million interpretations of this new rule. So everyone's kind of confused about it. The basic thing that I will say is in the past, pre-COVID, we had very strict control of respirators. OSHA has zero sense of humor, especially about respirators. They consider N95s to be life-saving, life-protecting devices. So they've got all sorts of wacky rules associated with it. And it used to be, you can't put on one of those darn things unless you're getting an annual fit test. And they were very strict about it. So that's been hardest for me to unwind in my head, because now they're like, everybody gets a respirator, you get a respirator, you get 2 respirators, so they're throwing the damn respirators around everywhere. But the new requirement for OSHA does not include an annual fit test for everyone. So it's been really hard for some of us to unwind our automatic settings, which is if you have a respirator on, it has to be annual fit tested. So that's one of the things I'll just kind of preface right there, is that there's a lot of confusion. I have seen some places are like, oh no, we're going to require annual fit testing regardless. And some places are like, oh, thank goodness, because we cannot manage to annual fit test 9,000 people in the next month, right? So it's kind of all over the place. So I'll clarify the new rule from OSHA, and this is federal OSHA, but Oregon OSHA is a pass-through recipient. They take federal OSHA rules and just apply them directly. Sometimes they do a little bit of supplemental rules, but in general, Oregon follows national OSHA word for word. So that makes my life a little bit easier. The new rule under federal and Oregon OSHA for COVID positive or suspect COVID patients is that a healthcare personnel who will be within 6 feet must wear an N95 or better. The rule does not include that that person must have a fit tested N95 unless they're doing aerosolizing procedures. So this would be airborne isolation. I can come up with a list for you, or you can find it on Google, but it is in general things like ventilated patients in case that vent tube pops off, CPR, endoscopy or invasive bronchs. It does not include things that early on everybody included, like nebulizers, high flow oxygenation, even like the swabs and upper airway scopy. Those kinds of things do not generate aerosol in the way that they believed they did initially, and so have been taken off of what's called the list of AGPs, the aerosolizing or aerosol generating procedures list. So if you need to find it, that CDC is the list that most hospital systems have adopted, and it is aerosol generating procedures, AGPs. So you can just look up COVID AGPs or aerosol generating procedures and look at that list. It does not include things like deep breathing, coughing, and other things that seem like they would aerosolize. And honestly, to some extent, it probably does aerosolize, but not to such an extent that you're getting enough viral load to get an initial loading dose and actually become sick. So this is after years of study, the year and a half or so that they've been tracking this, they've decided these are the procedures where people have been getting sick if they don't have respirators on that are fitted. These are the procedures that you could just wear a respirator. But just to confound us, they're still requiring an N95 or better. So in my world, you wear an N95 if you're worried about things that are aerosolizing. So this is kind of a point of confusion with OSHA. I think it's because it's really hard to track and monitor and manage the quality of simple droplet masks. Some of those are real crappy, just barely even just one layer thick. They have no liquid protection in case of venous splashes or other things. So I think this is just a kind of a cop-out decision by OSHA to say, you know what, N95s are more regulated, easier to identify. They are better for liquid protection. They will protect against aerosolizing if we haven't discovered that it's aerosolizing yet, or if the next strain is more aerosolizing. Even if it's not fit tested, it's still going to give you better protection because they also tend to be better tight fitting. So I think the reason for moving us to required N95s is it is simpler to enforce, manage, and then it opens up kind of the lower level PPE for the general population to buy up. That's me pontificating a little bit, but there has not been a lot of evidence of airborne transmission outside of airborne precautions settings. So don't let people convince you that suddenly Omicron is super airborne. The reproductive rate is about 8, so that is pretty transmissive for non-airborne. There is definitely an airborne factor, but if it was truly airborne in like normal patient care settings, my entire hospital population would have caught it by now, and they haven't. And we would see a basic reproduction rate of closer to like 12 or 18, like true airborne diseases. So the respirator thing is a rule and a compliance risk, not so much an exposure risk. So, and feel free to toss up hands if I ramble on and you find something in there that you want to dig into. Check out my notes and see what else I wanted to cover. So the short version there is OSHA is calling this the mini RPP, mini respiratory protection program. That's something else you could Google if you want to read the text of it. And the statement is, if you have a COVID positive or COVID suspect patient, the person providing care must have an N95 or better, and they must have some idea on how to do a self-seal check. And that's simply, it must be on, and when they blow out real hard, they don't see a bunch of, hairs flying around or feel leaks around the edges. And when they pull in real hard, they can see the mask kind of collapse a little bit, just appears to have a good seal. That is the minimum requirement for OSHA in a COVID positive or COVID suspect setting. That does not meet the minimum expectation for true airborne isolation. So this is one of the real risks here, is managing people who are all wearing an N95, and at a glance, you don't necessarily know that student's not fit tested. They just have what's called enhanced droplet precautions for COVID, which is droplet precautions with eye protection and N95 or better. So that's really difficult for us to manage, knowing who's fit tested and who's not fit tested, which is why a lot of hospitals are just saying, we're just fit testing you and making you wear a Papr if you can't pass a fit test. It's simply a safety issue of, at a glance, I don't know who's fit tested and who's not, and everyone's just wearing a respirator. One of the questions that I had brought to me was who should be in charge of providing PPE? I was a little surprised about this question. There really is an infection prevention issue of having people bring PPE in from home, especially if the PPE box is open. So I would push back a little bit if you're having hospital systems expecting your students to bring PPE in from home. Especially if it wasn't provided by the hospital system. I find that to be alarming. The hospital system is ultimately on the hook for protecting anyone within its walls who is being put into known hazard. So your students are essentially, as far as liability goes, a risk to them because they are employee type people that are knowingly being allowed to go into an area of risk. For that reason, a hospital administration, I think, should really be seriously worried about what PPE is being provided, what kind of training is being provided, because if that student catches tuberculosis, it is not just the instructor and the school administration on the hook. That patient and the risk associated is the responsibility of the hospital. So I personally would never permit anyone, students or personnel, to bring in outside PPE, because I don't know if it's been stored in a moldy closet or has some cat laying on it all day. I don't know if it's been stored within proper temperature controls. Once it's been opened, I don't know how the gloves been taken out and then stuffed back in. We really want these things to be controlled. And most of the hospital issues that we deal with are outside infections coming into our patient or coworker population, right? So even things like MRSA and other things that you don't know what is on the PPE once it's left the hospital. So keeping it in your car and bringing it into the hospital setting is not something that I would support. And I would definitely not support people just buying or storing their own PPE and bringing it in. I would push back about that a little bit. Let's see, what else do I have here? And then there's other reasons, it's not just to be picky about, we need to make sure that the PPE doesn't have latex, because that's a huge risk for our coworkers that the students might be around, and patients who have a high history of surgeries who have latex allergies. So there's just like a million reasons why I would not have students or others bring PPE in from outside. Let's see. And I did mention a little bit about OSHA standards are pretty picky about who's in charge of respiratory protection. There should be an actual administrator named in their policy for you to have questions or get clarification. And maybe I can put this in the chat. I'll have a little link here. Oh, and I see a question in the chat that I will respond to as well. For our students at Legacy regarding fit testing, why didn't it give me the link? We provide fit testing only for the students who are going to be going into airborne precautions. And at Legacy, the students that are actually going into airborne precautions are not the cohorted students who are actually accompanied by an instructor. Those groups are not allowed to go into airborne isolation settings or contact isolation settings, because it's a big group of you going in. It's not going to work. But those students who are precepted and are actually embedded, the kind of the final term students who take a semester and follow around a one-to-one preceptor relationship, those students are fit tested if they're going to be paired with someone who goes into airborne isolation settings, because we want the student to experience the entire breadth of what that level of nursing is going to be doing. So one of the things that I'll say we fit test the students, but it's difficult to see them before they come in. There's like an OSHA medical questionnaire that has to be completed. There's all these hoops because of OSHA. So what Legacy tends to do is anyone who's not currently fit tested on their N95, or we're using the half mask respirators in some settings as well. If you're not currently fit tested, you can't find your model, you don't feel comfortable with the fit for some reason, you go to the Papr Helmet. That's the positive pressure helmet. It looks, you've probably all seen them. It looks kind of like a bicycle helmet with like kind of a fishbowl around your head. Yeah. The glory about those is those are positive pressure respirators, and so they do not require a tight fit or a tight seal because germs don't swim upstream. So people who are super stylish and have facial hair and don't want to shave it can't wear an N95. They wear this Papr helmet to keep a pocket of clean air around them. And then, you can have leaks around where the facial hair is because, again, the germs aren't going to swim upstream. So you're safe in that. So what we do with our students who haven't yet been fit tested is we make sure they have access to a Papr helmet and give them a little just-in-time training. And then when we get around to it and it's convenient, we can get them N95 fit tested. But honestly, the Papr is easier to use, harder to screw up, and it's 4% more protective. Those are N99 rather than N95. So that's our default setting for anyone with a question around fit. And that's kind of so much easier than us trying to scramble it and do a bunch of students who, each school tends to have a start date that's a little bit staggered. So, but we are happy to fit test the students if they prefer an N95. We don't generally issue half mask respirators because those are given to the personnel to keep. We don't want to get those back and like decontaminate them. So generally at Legacy, they'll be N95 fit tested or Papr helmet trained as a student.
Yeah. Thanks, Brian. Are there any other questions? This is a lot of good information, and I'm just looking and I'm noticing there's a lot of nursing schools that had questions. I don't think they were able to stay. So thanks for letting us record this so we could have that. Any other thoughts? Any other questions for Brian? Yeah, this is like Brian, I appreciate this because this has been like a really confusing topic for people. Literally, it's been a very, very confusing topic. So
I guess I have one more thing that I see in my email with Wendy.
Okay.
If you're working for a hospital system that requires fit testing for N95, I would default your students to the Papr if they have those accessible, but those devices are super expensive. So some hospitals will not want your students in their Paprs. Yeah. If you're required to handle the fit testing yourself, I think that's a little unfair of the system. I think they should just make it accessible to you. But the fit testing is a real pain in the neck. There are a bunch of small businesses that do this. You can Google them, I'm sure, and find a million of them. Some of them, they do walk-ins, so you can just have the students go and take care of it themselves and just show up with a certificate. Some of them do on-site services. If that is the case, make sure that the hospital or wherever your student is being assigned is providing you the N95 that the student will be accessing while they're on campus. Otherwise, the fit test is very specific to size, brand, and model. And so if the student grabs a halyard duckbill, but it's just slightly off from whatever the duckbill is at the hospital they're working in, that fit is not sufficient. They're not actually getting fit tested. And if it's a requirement, then you might as well do it right. So just make sure if you are being required to handle the fit testing yourself, that you're being given the PPE that the student will be having available to them on that site.
Yeah. Thanks, Brian. And in the chat, Kelly put the question, what percentage of your staff need fit testing to perform their job duties?
That's a fun one, actually. So let's see, it's probably about 30% of Legacy personnel. I think we have just off the top of my head, I'm going to say we have about 5,000 people of our 15 or 14,000 personnel. So whatever that is, yeah, that seems to be about 30%. And again, these are only the personnel who work in places that have airborne precaution settings. So we're talking like negative pressure isolation and the ball on the wall indicator and the whole 9 yards. So those would be, folks who are inpatient only. We have only our pulmonary clinics have negative pressure settings in an outpatient setting.
Yeah.
Urgent cares don't typically have negative pressure settings. So emergency departments, we do fit testing, all the ICUs, ECMO, and a lot of the pulmonary, cardiopulmonary kind of places, because a lot of the infectious diseases tend to go into organ failure around the cardiopulmonary regions. And then all of our like endoscopies, cath labs. So it's basically, if you might go into an ICU or any department that has airborne isolation, or if you might need to do emergent care on an undifferentiated patient, emergency trauma, you don't know why they're coming in with a collapsed lung, so we're going to pretend it's infectious until we know it's not. And then things like life flight and kids transport, where you're stuck in a closed environment with the patient for a very long time.
Yeah. Great information. Any other questions? All right, Bryan, thank you.
Excellent. You'll probably see me again. Thank you, everyone.
All right, thanks, Bryan, and thanks everybody who came to the huddle and our after extended edition. Have a great week, and I'll see you all here next week.